Hello, and thank you for the invitation to join you at your Congress. I'm sorry I can't be with you there in person, but I'll be joining you by Zoom for questions at the end of this presentation. First, my statement of interest. Now about GINA, the Global Initiative for Asthma. It was established nearly 30 years ago with the goal of increasing awareness about asthma and improving asthma prevention and management through a coordinated worldwide effort. GINA is independent. It's funded only by the sale and licensing of its reports and figures. The GINA report is a global evidence-based strategy that can be adapted for local health systems and medicine availability. It's very widely used, with around 500,000 copies of GINA reports downloaded each year from over 100 countries. It has a very practical focus with multiple flowcharts and tables. The GINA strategy report is updated every year, based on a twice-yearly cumulative review of new evidence across the whole asthma strategy, and that includes reviewing published grade reviews when they're available. We pay careful attention to the clinical relevance of study designs and the generalizability of populations, and there's extensive external review. For a detailed description of GINA methodology, you can see it on the GINA website. Now first, about diagnosis of asthma. The definition of asthma includes two key components: variable respiratory symptoms and variable expiratory airflow limitation. And so it's very important to test before treating whenever this is possible, because it's often more difficult to confirm the diagnosis after inhaled corticosteroids are started, because inhaled corticosteroids decrease symptoms and they decrease variability in lung function and airway hyperresponsiveness. Unfortunately, spirometry alone does not rule in or rule out asthma, and so in many situations, more than one test is needed. The GINA flowchart about asthma diagnosis has been updated to emphasize the different approach that you need to take for the initial diagnosis of asthma compared with in patients who are already taking controller treatment. So the flowchart starts with patient with respiratory symptoms and asking the questions, are these symptoms typical of asthma? If they're not, then you need to undertake further history and tests for those alternative diagnoses. But otherwise, take a detailed history and examination for asthma. Does that support an asthma diagnosis? And then consider whether the patient is already taking asthma controller treatment. And you'll see on the left that there are two boxes in the GINA report that show you the diagnostic steps in patients who are already on controller treatment. But otherwise, the first step is normally to perform spirometry or peak flow with a reversibility test. And if that's negative, then other tests can be arranged. There is also the opportunity, if there's clinical urgency and if other diagnoses are unlikely, for an empirical initial treatment and then review of the response, but again try to undertake diagnostic testing within 1 to 3 months. Asthma is often underdiagnosed in low and middle income countries, and it's particularly difficult because the differential diagnosis often includes other endemic respiratory diseases such as tuberculosis, HIV/AIDS associated lung disease, and parasitic or fungal lung diseases. So a syndromic approach is often used for the initial phase of diagnosis. But as I mentioned, GINA recommends confirmation of the asthma diagnosis with lung function testing whenever possible before you start long-term treatment. Now, ideally, that should be with spirometry and with trained operators and calibrated equipment. If spirometry is not available, then peak expiratory flow can be used. The WHO suggests a 20% increase in peak flow 15 minutes after 2 puffs of salbutamol. And an alternative is to look for improvement in symptoms and in peak flow after about 4 weeks of inhaled corticosteroid treatment. However, as you'll be well aware, access to affordable diagnostic equipment and skills training needs to be substantially scaled up in low and middle income countries. I want to move on now to management, and starting with the risks of mild asthma. Patients who have apparently mild asthma are still at risk of serious adverse events. And this is one of the most important messages to convey. In several studies, around a third of adults presenting to the emergency department with acute asthma had symptoms less than weekly in the previous 3 months. And 16% of patients with near-fatal asthma and 15 to 20% of adults dying of asthma likewise had symptoms less than weekly in the previous 3 months. And you can imagine that the patient would not think that they are at risk of such serious outcomes if they have infrequent symptoms. In addition, exacerbation triggers are unpredictable: viruses, pollens, pollution, weather. And although oral corticosteroids are life-saving during acute severe asthma, even 4 or 5 lifetime courses of oral corticosteroids increase the risk of adverse outcomes such as osteoporosis, diabetes, cataract, stroke, and heart failure. So we cannot ignore the risks of apparently mild asthma. Now, as you know, low-dose inhaled corticosteroids are extremely effective in asthma. They reduce hospitalizations by 31% and reduce asthma deaths by more than 50%. And in patients with mild asthma in the START study, low-dose inhaled steroids almost halved the risk of serious exacerbations. And this was seen even in patients who had symptoms once a week or less at the start of the study, as seen on the left-hand side here. However, very few patients take inhaled corticosteroids regularly. They rely on their short-acting beta-agonist reliever instead. Now, from the patient's perspective, taking a short-acting beta-agonist for rapid symptom relief with an occasional course of oral corticosteroids is a very satisfactory treatment option for mild asthma. However, poor adherence is associated with an increased risk of severe exacerbations and death. And if patients overuse this SABA, that's associated with an increased risk of exacerbations and death. In addition, starting treatment with a short-acting beta-agonist trains the patient to regard it as their primary asthma treatment. So clearly, evidence was needed for a safe and efficacious alternative for treatment of mild asthma. So as you might remember, in 2019, we had that evidence for a fundamental change in GINA recommendations. The treatment of asthma with short-acting bronchodilators alone is no longer recommended for adults and adolescents. To summarize the evidence supporting these recommendations, the most important is that compared with as-needed short-acting beta-agonist, which is the treatment that most patients with mild asthma are taking, the risk of severe exacerbations was reduced by 60 to 64%, and this was seen in Sigma-1 and Novel Start. And then compared with the previous standard of care, maintenance low-dose inhaled corticosteroids, the risk of severe exacerbations was similar in the Sigma studies and lower in Novel Start and Practical, the 2 open-label studies. In terms of other outcomes, symptoms were slightly more, so an asthma control questionnaire of difference of 0.15 compared with the minimal important difference of 0.5. A slightly lower FEV1, around 50 mils, and slightly higher airway inflammation, around 10 parts per billion. But each of these 3 outcomes was stable over 12 months. There was no progressive worsening. On average, patients used the as-needed inhaler on around 30% of days, so the average inhaled corticosteroid dose was around 50 to 100 micrograms of budesonide a day. In terms of looking at the predictors of response, the outcomes for severe exacerbations and for symptom control were independent of baseline characteristics, including for blood eosinophils and FeNO, lung function, and history of exacerbations. Further evidence was available in 2022 for inclusion in the GINA report. And this came from a meta-analysis of all 4 clinical trials in just under 10,000 patients by the Cochrane collaboration. And this confirmed the large reduction in severe exacerbations compared with short-acting beta agonist alone, and the similar risk of severe exacerbations as with daily inhaled corticosteroid and as-needed short-acting beta agonist. What was new was that emergency department visits or hospitalizations were again 2/3 lower with as-needed ICS formoterol compared with SABA alone, but also significantly lower with the as-needed ICS formoterol regimen compared with daily inhaled corticosteroid plus as-needed SABA. So a more than 1/3 reduction in emergency visits or hospitalization translates into a large signal at a population level. Additional new evidence included analysis by previous treatment in the SIGMA studies, and this confirmed what was seen in the novel START study, that patients who were previously taking short-acting beta agonist alone did better with the as-needed ICS formoterol regimen compared with if they were randomized to the regular inhaled corticosteroid regimen. It's highly likely that they struggled more with adherence, having not been taking regular treatment before. Just a quick reminder about maintenance and reliever therapy in steps 3 to 5. This reduces the risk of severe exacerbations compared with inhaled corticosteroid or ICS LABA regimens with a SABA reliever with similar symptom control. And in many countries worldwide, maintenance and reliever therapy is approved for budesonide formoterol and beclomethasone formoterol. And you can see here on the left the reduction in risk of severe exacerbations compared with the same dose or higher dose of ICS LABA, and compared with conventional best practice. And then in the study on the right, where all patients were taking maintenance budesonide formoterol, the risk of severe exacerbations was reduced if their reliever was as-needed formoterol compared with the as-needed SABA in green, but the risk of severe exacerbations was lowest if the reliever was the combination of ICS formoterol. First, I want to look at this arrowed circle at the top, which emphasizes the key features of asthma management. First, when you're assessing it, not just symptom control, but also modifiable risk factors or so-called treatable traits, inhaler technique and adherence, and patient preferences and goals. And then treatment is not just the treatment with medications, but also treating those modifiable risk factors and comorbidities, non-pharmacological strategies, and education and skills training, including an action plan. And then when you're assessing the response, not just asking about symptoms and measuring lung function, but also asking about exacerbations, side effects, and patient satisfaction. Now, as I mentioned, the treatment figure is shown in 2 tracks, and track 1 has as-needed low-dose ICS formoterol as the reliever on its own in steps 1 and 2, and then with maintenance ICS formoterol in steps 3, 4, and 5. This track and as-needed low-dose ICS formoterol as the reliever is the preferred track because, as I've shown to you, using ICS formoterol as reliever reduces the risk of severe exacerbations compared with using a SABA reliever. Track 2 is still there though, because not everyone has access to ICS formoterol, and also some patients have been very stable for years on a treatment with a SABA reliever without exacerbations and having good adherence. However, when you are considering a regimen with a SABA reliever, you need to check if the patient is likely to be adherent with daily controller, because if they aren't, they're at increased risk of exacerbations. So in track 2, step 1 is taking inhaled steroid whenever SABA is taken. Step 2 has low-dose maintenance ICS, and then the remaining steps have maintenance ICS LABA. And then at the bottom of the treatment figure are some additional controller options for either track that have either limited indications or have less evidence for efficacy or safety. And this is a treatment figure that shows where you might start treatment in adults and adolescents with a diagnosis of asthma, depending on their baseline symptom frequency. For patients with mild asthma, if as-needed ICS formoterol is not available, then another option is to take inhaled corticosteroid whenever the SABA is taken. Now, there's much less robust evidence for this than in the ICS formoterol studies, but these two studies here have shown that SABA-only treatment is the worst option. On the left, published in 2007, a study using combination beclomethasone salbutamol, and this showed in blue that the worst option in terms of severe exacerbations was as-needed salbutamol alone, and the regimen with the least exacerbations was as-needed beclomethasone salbutamol. A study was carried out in children and adolescents, published in 2011, using separate beclomethasone and salbutamol inhalers. And you can see here again in blue that the SABA-only treatment arm had the greatest number of exacerbations. And in purple here, the children who took their ICS whenever they took their SABA, in this study they were taped together, had a trend to fewer exacerbations than the SABA-only arm. There have been 2 more studies also using separate inhalers with ICS taken whenever SABA was taken. In the BASALT study here on the top, in patients with mild asthma, symptom-based adjustment, taking ICS whenever SABA was taken, had a similar reduction in severe exacerbations compared with 6-weekly physician-adjusted treatment and 6-weekly pheno-adjusted treatment. And then a study with separate inhalers in children and adolescents showed similar symptom control and similar exacerbations compared with physician-adjusted treatment. I want to move on briefly to other changes in GINA 2022 medication recommendations for adults and adolescents. So we've emphasized that long-acting muscarinic antagonists, LAMAs, should not be used as monotherapy for asthma, in other words, without inhaled corticosteroids, because of a cohort study showing that they have an increased risk of severe exacerbations. The benefit of adding a LAMA to ICS LABA was examined in a grade review and meta-analysis published last year. And this showed only a small increase in lung function and no clinically important benefits for symptoms or quality of life. So the take-home message from this is that LAMAs should not be added for patients whose predominant symptom is dyspnea. Add-on LAMA provided a modest overall reduction in exacerbations compared with ICS LABA. But patients with exacerbation should receive at least medium dose ICS LABA before considering adding on a LAMA. And then one other note was that chromium pressurized metered dose inhalers, sodium chromoglycate and indocromal sodium, have been discontinued globally, although it seems as if very few patients were using these. The GINA 2022 report includes more information about the management of asthma in low and middle income countries. And this is crucially important, as you know, because 96% of asthma deaths are in low and middle income countries. And much of this burden is avoidable, particularly with inhaled corticosteroids. Now, as you know, there are many barriers to asthma care in low and middle income countries, particularly the lack of access to essential inhaled medications, but also the prioritisation of acute care over chronic care by health systems. Given the evidence I've shown you, the greatest overall benefit globally would be from markedly increasing access to low-dose ICS formoterol. But if that's not available, then the advice should be to choose the most effective in terms of reducing risk of exacerbations and the safest available medication. However, throughout the GINA 2022 report, we've described maintenance oral corticosteroids as last resort because of its serious long-term adverse effects. And so to achieve change in low and middle income countries, GINA strongly supports the initiative by the Union, the IUA-TLD, towards a World Health Assembly resolution on equitable access to affordable care for asthma. There are also many regional, local initiatives, and I know there are many in Vietnam. The importance of advocacy and lobbying for increased access to effective medications. But we also need evidence from low and middle income countries for the feasibility and effectiveness of the treatments that I've described. Training of health professionals is important, not just doctors, but also pharmacists and nurses. And we need to think about undergraduate as well as continuing education. It's important to understand the local context of access to medications in the health system, of cost, of stigma and concerns. And we want to emphasize the importance of doing the basics well: diagnosis, early treatment, inhaler technique and adherence, so that every microgram of available medication is used effectively. I just want to finish briefly with showing you the treatment figure for children 6 to 11 years, showing the options that are available. So several options available here in steps 3 and 4 for children in this age group, but still the key recommendation, because of the level of evidence, is for daily low-dose inhaled corticosteroid as a step 2 treatment. So far there are no studies with as-needed ICS formoterol in this age group, but studies are underway. And then for children 5 years and younger, the addition of considering intermittent short course inhaled corticosteroids at the onset of viral illness in children with infrequent viral wheezing and no or few interval symptoms. However, it's essential to consider side effects, particularly if the children have frequent viral infections. I just want to finish with a slide about COVID-19 and asthma. There's a set of slides about COVID-19 and asthma on the GINA website, and these are updated during the year as new evidence becomes available. So in 2022, further evidence confirms that patients who have well-controlled asthma are not at increased risk of severe COVID or of COVID-19 related death. However, the risk is higher in patients who've required oral corticosteroids for their asthma and in hospitalized patients with severe asthma. Interestingly, many countries saw a real decrease in asthma exacerbations during the pandemic lockdown stages, and this was likely due to social distancing, use of masks and hand washing that reduced exposure to additional respiratory viruses, including influenza. It's essential during COVID and to continue to emphasize the need for patients to continue their ICS containing treatment and to have an action plan so that they know what to do if their asthma is worse. The advice about aerosol generating procedures has been updated in 2022. So for spirometry, an inline filter reduces the risk of transmission during spirometry, but patients often cough after spirometry, so you should encourage them to stay on the mouthpiece if they feel that they're going to need to cough. And then about vaccinations, we've clarified the advice that influenza vaccination and COVID vaccination can be done on the same day. But we suggest that for patients who are on biologic therapy, that the first dose and COVID-19 vaccine should not be given on the same day, so that the adverse effects of either of them can be more easily distinguished. So as I mentioned, there's a full set of COVID-19 slides available on the GINA website. And most of the slides I've shown are available as a slideshow about updates in the GINA 2022 report that is available on the GINA website for academic and educational purposes. So thank you very much for your time, and I'll join you shortly for questions. Thank you.